Good morning, good afternoon, everybody. Thank you very much for joining. Hopefully you can hear and see me. Somebody can please confirm, that would be fantastic.
Yes, we can hear you.
Perfect, thank you very much. Yeah, my name's Robin Ward. I'm from Stockholm International Water Institute from SIWI in Sweden. And we have a very interesting session today, which is being hosted by UNICEF, SIWI, and others. We have two interesting sessions on outbreak response in WASH, the first being on mapping of the COVID-19 response by UNICEF and SIWI, and then the second part of the presentation will be about the alert response system that was put in place in Haiti to achieve 0 cases of cholera. So without further ado, maybe we'll move on to the first session. Unfortunately, my colleague from UNICEF has not been able to join yet, so I will take the floor, and then hopefully if he manages to join at a later stage, then he can also come into the presentation. So yeah, first of all, I have the pleasure to present on behalf of SIWI and also UNICEF this interesting initiative that we've done in partnership, which is about mapping the COVID-19 response globally in 84 countries around the world. So just to begin with, the objectives of the initiative, primarily, like the first objective was to develop what we call a COVID-19 WASH response framework with a number of kind of recommended generic WASH response measures. And the idea was to develop this framework that it could be useful to guide countries in their country level responses. And then based on that framework that we developed, the idea was, the second objective was to use that framework to do a kind of comprehensive mapping of the COVID-19 WASH responses at the country level. And the idea for doing this was to kind of identify in different countries what are some of the kind of good practices to enable like South-South sharing between countries on their experiences to try and strengthen the responses in different countries. And also the second part is to try and do this mapping to flag where maybe there's some potential response gaps. So just to give you a bit of a background on how this initiative how it started and how it's kind of grown and evolved. This slide shows the kind of a bit of a progression here. So initially, the initiative started based on a request made by the UNICEF Latin America Caribbean office back in March, like very early on when the outbreak was first kind of became big. So the Latin American office of UNICEF, they made a request to SIWI to develop a COVID-19 WASH response mapping framework, which was done, and it had 4 target areas and 38 response measures. And then this initial framework was used to map the responses in 15 Latin American countries. And then later on, it kind of expanded to the Caribbean. And then based on the success in this area, we expanded the initiative out to MENA region. And also the framework and the response measures within that framework then evolved further as we progressed and we learned more. And then we eventually progressed to mapping using this framework and doing the mapping at 84 countries across the world. So it really kind of grew in interest from UNICEF and partners globally. And just to say that, we've also continued now, like since June, we've been doing more targeted mapping in some countries and regions on the different phases of the crisis, so the de-escalation and new normality phase. And what you can see on the right here is a series of kind of technical reports and policy briefs, which have been released at various points along this process. And you can download them on these links here. So moving on to this is the famous framework that I was just mentioning now. which was developed with UNICEF and generally has 5 what we call target areas. So we move from target 1, which is more on hygiene promotion and for hand washing with soap. Then we move to IPC, infection prevention and control, and then on to ensuring that people meet their basic wash needs. And then number 4 is about ensuring the continuity and affordability of wash services. And then finally, we have the target for technical and financial support to utilities. So behind these 5 target areas, we have, I think, about 43 specific recommended response measures that were used in the framework and the mapping. And as you'll notice, these first 3 target areas are more aligned to focusing on households and institutions, whereas the final 2 targets are more around what support is there for utilities. In terms of the mapping approach that we took, as I already mentioned, we ended up mapping globally to 84 countries, and the map on the right-hand side gives you a bit of an idea of the geographical range of the countries. So we pretty much have, very good coverage globally, perhaps except for East Asia Pacific region. And in terms of the response measures that we are trying to find at country level of interest, we are interested in responses by all different actors, by governments, utilities, regulators, and non-government and private sector as well. In terms of the information sources, we did a purely 100% web-based search, and there was no limitation to the kind of information that we would include. If it was relevant to WASH, then we included it. And given the geographical scope, we also, made sure that we did searches in multiple different languages depending on the region. And once we found response measures, then we did a classification into the 5 different target areas, as we saw in the framework on the previous slide. But then we also tried to do a bit of classification depending on, the type of intervention. Was it led by the national or central state level, or was it led at subnational or non-state level? So in terms of information sources used, the most useful ones we found were to look on government websites, but also social media of government, where government websites may be out of date. And likewise for like water and sanitation utility websites, and also their social media links. And then also humanitarian development websites, and you see a few snapshots of those at the bottom. And then finally, we also used, of course, Google through different Google alerts using keywords surrounding WASH and COVID, and also general Google searches. So as much as this mapping is, of course, it's very interesting, it's very useful for countries, as we found, of course, it also has some limitations. And the first of these being that the mapping is of course, it's not likely to cover all of the WASH response initiatives going on within a country. And for this reason here, of course, that the mapping is based purely on secondary information available on the internet. And of course, we all know that you don't always find everything on the internet, and not everything you find on the internet is valid, of course. So what we also tried to do was where we found a piece of information and we mapped it, then we tried to verify it where possible with people actually in the country, so through UNICEF offices and other stakeholders. And another limitation, I guess, of this approach is that as soon as you finish an update, for example, by the end of May, then by the time you come around to publishing in June, for example, then a lot has happened between that 1 month period. So it's a very dynamic and rapidly evolving situation. So it leads to outdated snapshots. And then finally, we've mapped purely on what we found on the internet. We validated where possible and verified, but we haven't gone to the next stage, which is about qualifying the effectiveness of the different measures that have been identified. Just to give you a little bit of background about the matrix that was used, just so you have a bit of a picture. this slide here shows on the left-hand side a portion of the framework. So here we have, this is one of the target areas on the first target on hygiene promotion and hand washing with soap. And then under this, we had a number of specific response measures. And then what we did was we made the matrix here where we put a number of countries side by side from a region, in this case, North Africa and Middle East. And then whenever we found a measure that was relevant for this specific measure for a country, we filled in a box with an X, and we gave it a different color depending on whether it was a national or centrally led initiative, or whether it was a subnational or non-government led initiative. And then, just so you know, behind each of these crosses, we have a second tab on an Excel, and then behind there we have an extract of the text that's relevant, showing what happened in that particular country. So here in Sudan, there was 320,000 people that have received soap or other hygiene relief items. And then we give the date of the source and the source. Apologies. Okay. So in terms of results, so what we've seen is, you see these nice colorful pictures here of the different regions. And this gives you a kind of range, traffic light scale of the number of different response measures that were found in the different countries. And this is out of the 43 total measures. So as you can see here, there's both kind of disparities and differences between different regions and also within regions themselves. So I think most notably here, we see that in Latin America and Caribbean, and also in South Asia, there seems to be, more evidence of response measures than in other regions in Africa and East Asia Pacific and Middle East. And then in terms of the different target areas, we saw for all countries, perhaps unsurprisingly, we see a lot of focus on hygiene promotion, hand washing with soap, which is the target 1 area, and also WASH and IPC, which is target number 2. So this is target 1 and target 2 on these graphs. But then just to say that we saw significantly lower activity for targets 3, ensuring basic wash needs, targets 4 for wash service continuity, and target 5 for supporting water utilities. So as you can see here, this graph tails off as we go down through the different targets. And that's quite consistent across all of the regions globally. And just finally from me is to give you a bit of some more specific findings for different aspects of the responses that we found across all 84 countries. In terms of frequent response measures found, again, perhaps unsurprisingly, we saw a lot of pretty much all countries working on hygiene promotion, fighting misinformation, distributing hygiene supplies, focusing on washing healthcare facilities and isolation centers. We saw also a significant number of measures for ensuring continuity of water supply for households less able to afford and facilitate bill payments. And then, but on the flip side, in terms of some potential gaps, and we wonder whether this is, whether this is a gap in the response or whether this is merely reflecting a gap in the available information on the internet. The first potential gap seems to be that there was very little evidence found on ensuring continuity of decentralized sanitation, and also indeed for public bathroom access and ensuring that access to people outside the house. And then also we found only that around a third of countries were ensuring the continuity, only a third of countries were kind of taking steps towards ensuring a gender sensitive wash response at some level or scale. There was very little mention of strengthening and diversifying supply chains for water supply and wastewater treatment services. And then finally, which something that is quite alarming, I think, is there was quite limited evidence of technical financial support to utilities. and especially on analyzing, the economic viability of water utilities in the short to medium term. Now, we note from ongoing work done by World Bank and others that water utilities are, they're not able to fully cost recover. They're losing revenue at, up to 40% or more. And then at the same time, they're being asked to extend services at, a rapid rate. So they're incurring additional costs. They're less able to recover money, which means that they are using their capex, cash reserves to fund this emergency situation, which people are predicting that there might be a 7% capital expenditure reduction by water utilities this year, and maybe more going forward. So, yeah, potentially we see that there might be a bit of a crisis coming up where these utilities find themselves in a bit of trouble and not able to sustain services and not able to extend services to people that need them. So thank you very much. That's just to give you a bit of an overview of the initiative, and I would really welcome questions, or I think possibly my colleague from UNICEF, Albert, may have been able to join in the session now. So if he's here, if he can let me know, and then I can hand over to him.
Hi, Robin. Can you hear me?
Okay, perfect. Yes, thank you, Albert.
No, thanks to you. Yes, so yeah, please help me with the slides. So basically, we're going to briefly present you, how the tool, this mapping of good practices in WASH in COVID has been used in Latin America. So at the regional level, basically, to be very honest, I mean, all the emergency groups were not prepared, because for the first time, it was because of lockdowns and everything, it was very clear that it really was a government response and an operator and water utilities and response. So if you can click to the next one. So basically, what we did, the first activity was to use this framework. Can you click, Robin, please?
Apologies. Yes, I'm trying to click through, but it won't let me click through.
Okay,
Hang on.
So basically, it was to use to reshape this mapping. I mean, all these like 40 and so on activities into a national WASH response plan. In order to really, with indicators, with yeah, now we can see the screen. Yeah. So basically, we've used exactly the same lines, but we've detailed them as per probably like sub activities when needed, or to put to indicate baseline data, and obviously to frame it also as indicators, and as you can see in the columns, like numbers. I mean, which partner is doing it in which area, and the budget. So I think it was very useful. Together, like 9 countries in the region used it as a complete WASH response plan at national level, and 3 others used it partially because they already had their own plan. So if we move to the next slide, please. So at regional level, so basically, I mean, this the mapping has received like a very good recognition from the World Bank, EIDB, Spanish cooperation, the Global WASH Cluster, universities like Tufts, and also SWA, Sanitation and Water for All, as well as UNICEF headquarters. And so, for example, it has been used by Sanitation and Water for All in a closed door webinar with sector ministers at the beginning, mid-year. We used it as a basis, and we've developed a policy brief together with the World Bank, with SIWI, and UNICEF, like in August. Right now, there is an ongoing process with many actors from the government of Colombia, Ministry of Housing, with leading on WASH, Ministry of Health, Education. Yeah, sorry, a mistake here. CRA, who is the regulator for the Water and Sanitation Authority, NGOs, Action Against Hunger, and foundations, and as well as several small utilities association. But then again, like international cooperation, to also prepare like a lessons learned and way forward. What is very interesting is that there is also, it's not only this year, but next year we'll continue with EIDB, SIWI, and UNICEF and the WASH group to build a toolbox to build the resilience, to provide tools, to build the resilience of the wash sector in health emergencies, and also with SIWI, UNICEF, and also the regional education in emergency and wash in emergency group. We will also work on specific policies and good practices for the safe return to school. If we move to the next slide, thanks. So at country level, I mean, the mapping has been used directly, not as an emergency plan, but really as a mapping. It has been used to advocate at the UN system in Colombia. It has been used and shared with the mayors in Ecuador, also used for the regulator in Ecuador to reshape its questionnaire to the utilities during COVID, but also it helped to strengthen the national wash in emergency platform in Ecuador. In Paraguay, I mean, basically it's helping to advocate. I mean, it has been advocating for like subsidies to small operators. In Honduras, for example, it also helped the regulator to really understand the gap of information, and it led to a survey. In Guyana, it also led to not disconnecting users, and in Bolivia, you can see the mapping now. It really helped. It has been like a green mapping, because at the beginning we did it it was in blue, and people thought it was just a wash mapping, but no, it's really a prioritization for COVID, so all sector together. So it's really prioritization, and it's a key element of this framework. And the last slide, please, Robin. It's just probably to explain. On the left-hand side, you've got like a emergency sector, I mean, wash sector. On the right side, I mean, the more development thing. And in between, it has been quite a poorly made intent for me to really show that that when we mix colors, it transforms these two. It transforms into green. Basically, I think really this framework is really transformative for the wash response in emergency. Because it really connects very well the emergency and development links. So it can be probably, I've put in red, so lasting behavior change and coordination are probably parts of this coordination of this framework that needs to be developed a little bit more. But I mean, I guess all the elements are there, definitely. And the good news is that we also have a monitoring tool now that has been developed at regional level to make sure that we can monitor this response plan, but also any other response plan for any wash emergency, and especially also in between emergencies when we do the resilience construction. So definitely, I think it has been a well-used, not only a theoretical exercise, but it has been definitely used in the field at all levels of different actors. So thanks a lot. And I think with that, I will hand over directly to the team who will present us basically the cholera eradication in Haiti. Thanks again.
Thank you, Alban. Welcome. My name is Paul Christian Nanfi. I represent DINEPA as the National Cholera Response and Elimination Coordinator. This side event is about the elimination of cholera in Haiti. It will be in 4 parts. First, a presentation on the role of the government and of DINEPA, followed by a second about the alert response mechanism by UNICEF, and a third presentation by Action Against Hunger ACF USA to give us an implementer's point of view. We finally close the event with a short Q&A panel with 2 experts invited to answer your questions. So do not hesitate to write your question in the pathable box. Do we have the presentation loaded? Great. Okay. And the next slide. Slide. The next slide, please. Can you please advance the slide?
Can you see? This is your presentation. I'm not sure that this is.
Who is advancing the slides?
I am. Can you see my screen?
Yes. The next slide, please.
Okay. This is your first slide, actually.
Yes, the next one.
If you just push the down arrow, you should be able to get to it.
You let me know?
Yeah, the next slide, please.
Not this one?
No,
No,
number
the
2.
next one.
That's the last slide.
No, sorry.
Yeah, apparently what we see on the screen is not the same thing as what you see on your own screen, apparently. So. Yeah.
Oh, I'm sorry.
So
Do
maybe
you see-
stop sharing and share again, maybe. I suggest, Christian, that you continue, because otherwise you will be constrained with time.
Can you see it right now? Is it?
Yes,
is
yes,
it-
it's back.
Go to the next slide.
Okay.
Okay, great. All right. So we're going. Okay, as illustrated here, cholera established a catastrophically lethal foothold in Haiti in October 2010, spreading from Mirebalais commune in the Centre down the Artibonite River, and then throughout Haiti, particularly strong in 4 departments, the Centre, the Artibonite, the North, and the West. And it exacted an incredibly large toll in just over 8.5 years, over 280,000 infections and nearly 10,000 deaths, according to Health Ministry data. A major factor in the ease of cholera spreading and of dissemination was the extremely low water and sanitation baseline existing in 2010, particularly in rural Haiti, conditions favorable for cholera transmission. Access coverage rates in piped water actually decreased 4% in the period between 1990 and 2015, which was mostly prior to cholera's arrival in Haiti. In response to this challenge, Haiti's public sector, both the Public Health Ministry and DINEPA, which is Haiti's National Drinking Water and Sanitation Authority, responded with a 4-pronged approach. First of all, a 3-access coordination system, Health Wash, government partner multilateral organization, this at the national, departmental, and communal and local levels, to ensure effective use of resources and gap filling regarding the battle against cholera's needs. The next 2 parts are, first of all, the case area targeted intervention, CATI, which will be discussed later with its cordon sanitaire, but I'm stressing here its significant effectiveness in mitigating and shortening cholera outbreaks in Haiti. This became the most important factor in cutting cholera transmission, eventually leading to 0 confirmed cases. And in parallel, we see on the DINEPA side, the strategy of chlorinating all the water that populations consume in the outbreak areas. We call that reactive wash, supported by partners, particularly with chlorination activities, highlighting key roles by the regional offices of DINEPA called the OREPA, and the commune level agents, the ASEPA and the TIPAC, both in urban and rural areas. And finally, on the bottom, transitioning to more developmental interventions, the prioritization of wash interventions in cholera incidence communes. This will be discussed in the next slides. Haiti's public sector's main tool in coordinating the battle against cholera was the Elimination Plan. Beginning by drafting a 10-year document at the end of 2012, Public Health Ministry, MSPP, and DINEPA introduced the key updates and recalibrations during the 10 years, the midterm, mid-2016, and the long-term, November 2018. The midterm formalized this alert response mechanism as a pillar in the battle against transmission, along with access to water and sanitation in hotspots and health and hygiene promotion. The midterm document in 2016 also redimensioned budgetary figures to a price tag of only 178 million, which was only 8% of the original 2.2 billion of the 10-year plan. So this could then be more feasible to attract donor responses leading up to the long-term document, which was 390 million over the last 4 years. Key in the midterm and long-term were the geographic prioritization of WASH investments in high cholera incidence areas and focusing on integration of the battle against cholera in the overall health system. This map shows how the midterm elimination plan selected 18 of Haiti's then 140 communes for enhanced WASH interventions by priority rank, 7 in the highest priority, which is the darkest red. Commune action plans were then drafted for Mirebalais, Inche, Gonaïves, and Quadibouquet-Canalan, using an operational research methodology championing City Hall and the OREPA, the regional offices, and drafting plans of particular intervention, the PPI. Basically, these were recipes for WASH improvements within the highest impact on cholera vulnerability abatement. So that is the best way to get to reduced vulnerability to cholera. we see here that identify, assess, and implement. Basically, where is the highest incidence occurring? We're using that operational research to know exactly what are the risk factors. And finally, of course, the bridging project in terms of the implementation, long-term water supply systems, and on the sanitation side, the ACAT, which is an adaptation of CLTS. And just before we go to this slide, we just wanted to mention 4 key communes, which give you kind of a snapshot. Mirebalais, 2010, that's where the outbreak began in this Département du Centre. Second of all, Saint-Michel de la Talaye, which was a persistent area of cholera, but through improved water treatment systems and household sanitation in conjunction with local authorities, we were able to get that under control. Cornillon in the west on the border with the 2018 outbreak and the MSPP-led SWORD operation to cut transmission. And finally, Lestère in the Artibonite, where the last outbreak was. And ACF will be talking a little bit later about how they provided independent water systems when the urban water supply failed. Next slide. So finally, the next steps for Haiti, washing cholera, the context. Population is protected against the reintroduction of cholera and other waterborne diseases. So first of all, the integration of the battle against cholera and other waterborne diseases in the overall health system. WASH programs in waterborne disease risk areas, WASH access and water quality monitoring. And we have a tool at DINEPA called the BPO, Budgeting Planning by Objectives. This is the larger framework for sector planning. The idea in the long-term cholera plan was to start with the BPO investments where you had high cholera areas, and the costing was completely consistent with BPO. As you see on the right side, 2/3 of the BPO budget was for access to drinking water. Thirdly, cholera and other waterborne infectious disease monitoring and surveillance. And of course, pivoting toward the current worldwide health priority, which is the battle against COVID. So ACF, Action Against Hunger, will compare and contrast the battle against these 2 fatal pathologies and also focus on the 2019 efforts in Lestère. I now pass the mic to Finid Beauséjour of UNICEF, who will present on cholera elimination techniques within the global roadmap framework. Thank you.
Thank you, Paul. So good morning all. My name is Finid Beauséjour. I am a physician and emergency specialist at UNICEF Haiti. I will be presenting this part of the session with my colleague, Gregory Boulit, who is a WASH specialist at UNICEF headquarters. So we're going to describe the strategy that is put in place in Haiti to achieve 0 cholera case and share with you some interesting lessons from the Haiti's experience that hopefully can be useful for other countries. So, but before starting, I will invite you to check out our first poll question. And after the session, you can also watch this short video on how community outbreak response teams deliver the case area targeted intervention. So, October 2010, exactly 10 years ago, the deadly bacteria was introduced in the small affluent of the Artibonite River in the Central Department after the illegal dumping of the contents of a UN peacekeepers' latrines. The fecal sludge ended up in the river, which is actually used by a large number of population. As a result of this negligence, recognized since then by the United Nations, nearly 900,000 people have been infected, and almost 10,000 persons have died. But those are official numbers, of course, but there were certainly more affected people than reported. This is also a dramatic reminder of the importance of having adequate level of WASH services in all countries. So as we can see on the top, on the slide, or on the graph on the top of the slide, the huge peaks occurred in 2010, in 2011, in 2012. And after that, we have what many people call the endemization of the disease. However, the last positive case has been confirmed 20 months ago, back in February 2019. So this is an hypothesis that the disease is not anymore in transmission in the Haitian population. So this hypothesis is supported by the result of more than 1,800 samples taken from both suspected and non-suspected cholera cases. It's also very important to underline that those tests as part of an effort of an ongoing reinforced passive and active surveillance, which were accelerated from 2017, as you can see on the graph to the right, on the bottom of the right. And so these graphs show both the progressive reduction of positivity rates, especially starting 2016, and also the increasing, in orange, increasing of waste sampling up to 156%. So the question is how Haiti is achieving cholera elimination. Well, we don't have all the answers, but we would like to present you the strategy that has likely contributed to reach 0 case over the past months. So now I will hand over to my colleague, Greg.
Good morning, good afternoon, everyone. My name is Gregory Bullitt. I am WASH specialist for UNICEF. Before starting, allow me to remind you to answer the poll questions. This is important for us. So in the next few slides, I will try to quickly present the alert response strategy used in Haiti, a strategy centered around the CATI approach, which aims to stop the transmission in households and communities. So be reassured, the CATI approach will be further explained by the next presenter. We also take advantage of today's event to inform those interested in learning more about what was done in Haiti, that you will find in the files of the session a short chronicle telling the story of the response in 2010 with a focus on the last 5 years. Next slide, please, Fanny. Thanks. So in this graph, you see that the fight against cholera in Haiti is a succession of events, both in terms of epidemiological trends and control interventions. The green bars on the graph represent the number of weekly cases nationwide. The dark red bars, the number of cases in Port-au-Prince region, and they are very important. And the blue line, the number of response teams, and the blue bars below the weekly rainfall in millimeter. So the alert response system started in 2013. Then a few events framed the system, like the major outbreak in Port-au-Prince in 2014, where we as responders realized the urgency to improve the surveillance, because this flare-up was mostly due to an important underreporting. Then from 2015, the cholera trend alternates with flare-up and low transmission periods that one may consider like as a seasonality of the disease. And also the response intensity varies depending on available funding, and therefore the number of response teams also vary. It's only by mid-2016 with additional funding that the number of teams became stable, and that we could complement the CATI interventions with more community-wide activities, like the high impact operation in Port-au-Prince that resulted in the disappearance of the red bars, as you can see, and I will explain later this operation. So we believe that all of this contributed to progressively cut the transmission in the country, so that neither the last hurricane in 2017 nor heavy rains the next year, were able to invigorate the disease. So I'm not going to enter into many details here. The next presenter will give more information on this alert response system, but this slide shows basically the 3 layers of the system in Haiti. With on the right, you can see the first level of rapid response intervention, the second level of preventive WASH activities, and the last level or layer of enabling factors like a strong surveillance and a strong coordination. We are often asked what is the rationale for the CATIs. Well, a study published in 2016 confirmed that the relative risk of being infected within 3 days for a person living within 50 meters of a case is about 36 times higher compared to a control group out of this range. So yes, this somehow justifies quick intervention in this perimeter and in this time frame. But what kind of intervention then? Here, although not the same exact methodology than the CATI, the CHOBI7 trial in Bangladesh showed that interventions targeting households with water chlorination tablets or support to hand washing contributed to decrease cholera infection and also resulted in a higher uptake of hand washing practices. Next slide, please. Thank you. But the CATI or even the alert system response is not just about sending a team to do a response. In Haiti, it was supported and it is still supported by a strong monitoring, which has been essential to drive the response. The table here illustrates a key element of the philosophy used in Haiti, which was never stop tracking cholera cases or suspected cholera cases and always try to intensify the response even during a low transmission period, particularly in residual hotspots. So we can see here, for instance, that the percentage of cases being responded within 48 hours, or the size of the cordon sanitaire, which is the number of households reached around the case, or even the ratio of people reached with awareness activities always increased over time, despite a lower annual incidence. So this is basically the contrary that many countries are doing when fighting against cholera, when a response is just started or scaled up only during outbreaks, which is often too late. Next slide, please. Obviously, measuring the effectiveness of the CATIs remains a challenge. We know that. Several prospective studies are ongoing, which hopefully will give more insights on how the mechanism reduces the transmission and, most importantly, how it can still be improved. However, the results of a retrospective study published in 2019 suggest that prompt and intense responses were able to decrease outbreak duration and the number of cases for particular localized outbreaks. Next slide, please. In conclusion about the alert response, I would like to reiterate that the system is not just about sending teams to do something in the community. And it's not sending house spraying teams, because I say that because it is often a rapid summary to explain what the cholera response teams do. So it's not just about spraying houses. It is a system that depends on a strong coordination and surveillance, which are mandatory. And in addition to the CATIs, it relies on broader community intervention in affected community, like bucket chlorination or support to water system chlorination, local influencers engagement, etc. And as an example, I will explain briefly what has been done during this high impact operation in Port-au-Prince in 2017. Next slide, please. So this operation is a West Department Health District and DINEPA led operation promoted by UNICEF Haiti. And the objective was very simple. In summary, we wanted to counteract the seasonality that many thought to be ineluctable. That is why this operation, as you see on the top right, started before the high risk period. So starting July 2017, all alert response components were intensified. It was a daily situation room to guide activities, hundreds of municipal agents working in public markets or religious leaders trained about cholera prevention, and also adding more teams to do the response. Those teams were coming from nearby departments, so that 95% of all cases were responded within 48 hours during this operation. As a result, as we saw on the first graph with the dark red bars disappearing, the transmission of cholera in Port-au-Prince stopped, which also slowed down the transmission in nearby departments and eventually resulted in cutting the transmission all over the country. So I thank you for your attention, and I will give the floor back to Fenit now. Thank you again.
Thank you very much, Gregory. What are the main lessons? So we will keeping from this Haiti experience. So the first one is that it is important to believe in the possibility of elimination. This conviction was a big motivation to do better and to convince donors to continue their support despite many competing priorities around the world. Second is that it's important to support national and local leadership. The overall coordination of the response has been done by the government through the Ministry of Health and the DINEPA. And without this leadership, the current result would not have been achieved. It is also important to engage with all communities and local influencers. So the major lesson is that in any kind of emergency setting, community empowerment and engagement should be among top priorities. And as we see with Greg, surveillance, sharing data surveillance with community responders, tracking continuously cholera, even when the transmission is at its lowest, and also harmonizing all the intervention among partners, and finally adapting the response continuously using data and monitoring data and also research. All of that are very important. And finally, we need to secure funding. It's not only about the emergencies, but also it's part of building a health system. As a matter of fact, for example, here we are using in Haiti, all the structure, the cholera structure to fight COVID. So all those resources that have been put in the system are still used right now to fight COVID. So this is a very important thing. As we said, there are no confirmed cholera cases since February 2019, but the elimination is not yet here. So as per the WHO recommendation, it is not only before January 2022 that the country could indeed declare itself free of cholera. But in the meantime, there are ongoing efforts to sustain the gain. The first thing is to keep active and passive surveillance and laboratory testing. We are still also sustaining all the awareness activities, and now they are coupled with COVID-19 prevention and response. We are continuing advocating for accelerating wash improvement in high-risk areas, and also keep surveillance, environmental surveillance, to verify the absence of the bacteria from the Haitian environment. And finally, we are keeping evaluating the effectiveness of the CADIs to improve the system. So I will also take this opportunity to pay tribute to all partners that contribute to this incredible achievement. First, the government through the Ministry of Health and the DINEPA for their leadership and commitment. Second, the rapid response team members who started since 2013 and are still working relentlessly for 6 years. The donors, they believe in the program and they supported it over time. And of course, all the NGOs partners, as they have been the cornerstone of the response. And last but not the least, the community. The community, despite all the suffering, the loss, they kept faith, and they were a critical stakeholder in the fight against this epidemic. So I say thank you for your attention. And before passing to the next presenter, Bram Reams, I would like to invite you now to go again to the poll and answer question 2. Again, thank you for your attention and participation. Brahms.
Good morning, everybody. Can you all hear me?
Yes, I can hear you.
All right. My name is Bram Reams. I'm with Action Against Hunger, and I will talk a bit about our experience as a field implementer in the decade-long cholera elimination effort in Haiti. This session, as you might have seen, is also a bit of a celebration, actually, of what has been achieved so far. And touching wood, but hopefully we really get to achieving cholera elimination in Haiti. Next slide, please. So this is a photo of one of our teams working in the field. They're sensitizing people on what they can do to prevent cholera. And as you can see from the testimony on the left, many people thought that cholera was there to stay up until the very last moment, 2008, in a formative research we did. And as Finny said before, it's really thanks to the relentless efforts of these teams that for more than 1.5 years now, there's no new cases that have been detected. Next slide. As was explained earlier, the first cases in Haiti appeared in the center department, and then they really quickly spread to the Artibonite department, where access to safe water was really, really low. And then a lot of the water sources that were considered to be improved water sources were actually contaminated. In the first 2 years then, 2010, 2012, the response was haphazard. Mainly consisted of massively distributing hygiene items, doing mass sensitization, but without a clear division of roles, and also without much effect, because cases kept resurging, often in the same communes. As you can see on the map, there's 2 departments there that are colored in red, the Artibonite department and the Nord-Ouest department, which are the main intervention areas of action against hunger. Next slide, please. So from 2013 on, when coordination became much better, Action Against Hunger became one of the organizations that started implementing the case area targeted interventions. Those were done around a suspected or confirmed cholera case to break transmission. And as you can see, the response teams were essentially composed of a team leader. You had at least one person who did the household spraying. You had a hygiene promoter, and you had a staff from the Ministry of Health, essentially to administer chemoprophylaxis to contacts. In practice, teams, they would first establish a sanitary cordon of about 20 households. And then after the sanitary cordon is established, they would start engaging more with communities and in doing other control efforts. Action Against Hunger did between 2013 and 2017, so not considering the past years, we did over 3,200 CATIs in our intervention zones, most of which were implemented within 24 hours. Next slide, please. So how was this done in practice? So everything really begins with a good surveillance system. Suspected cases, they could reach us either through a community-based network or from the line listing from cholera treatment centers. Those data would be collected and analyzed, and they could inform other interventions such as cholera vaccination. But from the moment really when we received a case, a notified case, this would immediately trigger a field investigation and a CATI response. As you can see there, the CATI response essentially consisted of detecting additional cases, distributing cholera kits, spraying in the household, sensitization, and administering of antibiotics. Finally, Action Against Hunger started to work more on market-based approaches as well. That was from 2017 on, namely to produce, to promote water treatment products and reduce dependency. Next slide, please. Since the start of the CATI approach, our interventions also improved over time. As you can see there in the graph, we more frequently implemented CATIs to their full extent. This was especially the case starting in the spring in 2016. We also responded faster. We went from response time of mostly 48 hours towards 24 hours. And finally, we responded to more households as the sanitary cordon increased. And this was also done to reduce stigmatization. Next slide. Now, from our point of view, there's definitely a number of advantages to the CATI approach and how it was done in Haiti. First, the coordination meetings at all levels. Also, as Paul Christian mentioned, the existence of the national framework was very important. The fact that this approach was the same for everyone and allowed also then towards the end to analyze its effectiveness. Another strength, I'd say, that members of the surveillance network really knew how to recognize and describe a suspected or confirmed cholera case. This is absolutely critical. And then what I definitely also see as a strength is that most teams, the response teams, came from the communities themselves, and so they were easily accepted. Next slide. So here's two examples of why I really believe we were successful in our intervention zones. This is Veline to the left and Tresilio to the right. And they have been with us since the very, very beginning of the outbreak. They were also afraid and very vulnerable at the time, 2010, 2012. But as they learned how to become a lot more effective, we also became a lot more effective as an organization. And we're glad to have them still with us today. Next slide. This is another strength. It's longer-term water treatment when there's no alternative. So this is a water treatment unit that we set up in L'Estère commune, which is where Haiti's last outbreak occurred in 2019. And the unit stayed there for over a year until 2020. Unfortunately, today, we see that people are reverting back to drinking water from the river, which was identified at the time as the source of the last cholera outbreak. Next slide. And this brings me also to some of the challenges in our experience. The first one is linked to the funding cycles. Funding cycles mostly were very short for an effort that's essentially long-term, so high administrative burden. Next, quite a bit sustainability issues, both for wash infrastructure as well as for long-lasting behavior change. And then finally, I'd say at the time, there was limited evidence base for some of the interventions we were doing. And there's maybe limited evidence base for some of the activities that we're doing today. I would like to mention that we have Danielle Ontani from Tufts University in the panel. She might be able to give some insights into the effectiveness of some of these interventions. And if you have any questions, please type them into the chat. Next slide. So back in November 2019, all the partners in Haiti national level came together and during a cholera workshop and deliberately decided to keep a cholera response capacity. This was more than 6 months after the last case was notified. Then 4 months after that workshop, the first COVID-19 cases were notified. So the cholera response capacity sort of automatically led was used to respond to COVID-19 as well. Now, what are the similarities? First, the coordination mechanisms, they are basically the same at all levels and with a high frequency. Second, the surveillance network, once members were trained on COVID-19, recognizing its symptoms, this was really used for COVID-19 as well. And then finally, even the rapid response looks very similar, although there are some differences. The rapid response for COVID-19 is done based on confirmed cases only, so you need a lab test. This is taking time. This wasn't the case for cholera response. The sanitary cordon is also being used for COVID-19, but for a smaller number of households. And then finally, the intervention is also slightly different because there's no spraying. Instead, there's cleaning of high-risk surfaces. Next slide. So the Haiti experience really influenced how we as an organization respond to cholera or attempt to respond to cholera in the future. We are finalizing now our new standard operating procedures. We will conduct CATI or very similar to CATI in other countries too. And we also intend to work with Johns Hopkins to assess CATI effectiveness in other countries. So I want to thank you for your attention and invite you to complete the final poll question, which is, do you think the CATI approach could be useful to respond to COVID-19?
Okay, can you hear me? Okay.
Yes.
Hello everybody, bonjour à tout le monde. I'm John Mark from the French Red Cross, based in Paris, France. We now have a 15-minute Q&A period with two experts. Let me introduce them to you in a few words. First expert is Danielle Lantagne. Hello Danielle, how are you?
Hello, I'm doing well. Thanks for having me.
Okay, so Daniel, you are based in Boston, where you are an assistant professor at Tufts University. Over the past 15 years, you provided technical assistance and evaluation in more than 50 countries in both development and emergency contexts. And your main research interest is how to develop and disseminate interventions that reduce the burden of diarrheal disease and cholera in both development and emergency contexts. Thank you, Daniel, for joining us today. The second expert is Stanislas Robaudet. Hello, Stanislas, how are you?
Hello, can you hear me? I'm fine.
Yes, very well. So Stanislas, you are based in Marseille, south of France, and you are a medical doctor specialized in infectious and tropical diseases at l'Hôpital Européen de Marseille. You are also a senior researcher in public health. And we can say that you know the subject very well because you provided the Haitian authorities and UNICEF with regular epidemiological and strategic analyses about the cholera epidemic between 2013 and 2019. Last but not least, in 2013, you proposed with Professor Renaud Piarou the CATI strategy to eliminate cholera in Haiti. And then you coordinated the assessment of CATI's implementation and effectiveness in Haiti. So thank you, Stanislas, for being with us today.
Thank you for inviting me.
So having a quick look at questions, we have one question in the chat. So maybe for you, Stanislas, could you go over the reach of the surveillance system within each department in Haiti?
All right, so I have to do a bit of history of this surveillance system because it changed quite a lot along the years in Haiti. In fact, pretty early during the epidemics, from November 2010, a national institutional surveillance system was set with the help of the CDCs. And in fact, every day, the total number of new cases and deaths recorded at each cholera treatment center was sent from these centers to the departmental level, to the department health directorate. And then it was sent to the National Epidemiology Directorate. And these analyses, these data were compiled and analyzed. And in 2013, we proposed the Directorate of Epidemiology in Port-au-Prince to add daily alert system, which proposed to summarize all these informations to provide a map, an alert map with 3 alert colors, red, orange, and green, so that everybody could follow up the evolution of the situation and could advocate for a better response in the most affected communes. And then there was, in fact, this alert system was something asked by the WASH actors because they were complaining that the surveillance system was only provided like numerical figures, and there was no really way to understand the dynamics of the epidemic. So we worked together with the epidemiologist of the Ministry of Health to provide something more easy to understand. And then in 2013 and 14, there was a dramatic change in the surveillance system because with the help of the Ministry of Health, we could set, and the help of the several WASH actors who were working on CATIs, we could set department line lists of all patients. So that we could have the address, the precise address of every suspected cholera case who was arriving at a treatment center. And these informations were shared on a daily basis and sometimes even several times a day with the actors implementing the CATIs. The NGO actors, but also the Ministry of Health teams, so that the CATIs could be really targeted at the right place to the family of the cholera suspected cases and their neighborhoods.
Okay, thank you, Stanislas. Maybe for you, Daniel, now, regarding the CATI approach, what are the components of the response that contribute the most to prevent or to cut the transmission? And what are the components for which we need more research?
I think when we think about CATI, there's all this amazing evidence and experience from the field, from examples where it's been done for years and it's been successful, that's out there. And then there's a critique somewhat, and I think it's an unfair critique, that there's not enough research about CATI to show if it's effective or not. So some people will say it may not be effective. And I think when I think about, there's the implementation of CATI, which everyone's described really well, and I think it has been successful in Haiti at reducing the cholera. When I think about researching it or adapting it to other countries, I think about kind of two components, and those have both been addressed and talked about here. One of them is the management aspects. How do you get to the houses as quickly as possible? How do you have an address list? How do you have the teams ready to go out? What's the operations there? Where do you station the teams? And I think we know that it'll be more successful the faster you get to the households. And so in some other countries where we've also researched CATI implementations, there can be delays of 3 to 5 days to get to the household. And the idea, what's being said here in terms of reaching 95% of the households within 24 hours, that's really going to help in terms of having a successful CATI. So I think at one side of things, there's this whole idea of what's the operations, what's the management, how are the teams managed? And then on the other side, what do they give? And I think we do have good research on a number of the interventions that are handed out. There's a number of organizations, LSHTM, Johns Hopkins, et cetera, CDC, that are researching, and we've researched some as well, in terms of researching the success of the intervention. So bucket chlorination, can you add the right amount of chlorine to inactivate the cholera in the drinking water? Household spraying, can you spray successfully by fully coating the surfaces that are likely to have cholera on them? The educational aspects that are asked about in chat, can you provide education during these CATI visits, right? And I think one thing to think about, LSHTM with Rouen has been doing some research about linking not just WASH, but also could you add a vaccine or a prophylactic antibiotic, right? And could you add other things in? Now, the exact set of components, many of them we know can be successful if they're well implemented. The exact set of components, and I think this is really well talked about here, for cholera might be different than COVID. But the idea of if you could have kind of an operation and operational structure that can get to the houses as quickly as possible, plus the interventions that are appropriate for the response itself, depending on the disease, cholera or COVID, that's when I think you can really see these successful CATI interventions. And I think it's hard to research all of that at once. And so if you hear the critique CATIs are unresearched, we don't know, it's because I don't think anybody's to date, although CDC and Hopkins and LSHTM are working on it now, researched the whole of it, But when you look at the pieces and how it comes together, I think when you put those pieces together, rapidly getting to the households with interventions that are shown to work in the context to reduce the disease you're looking at, that's when I think it can be really successful. And we need more research of what's the package that's most operationally efficient for the disease. Should it be a vaccine plus household spraying plus bucket chlorination plus education plus prophylactic antibiotic? Probably too much. What's the right package in each place? And I think that's kind of the research that we really need to look at.
Okay. Thank you, Danielle. It was very clear. Another question maybe for you, Paul Christian or Bram. Cholera transmission has stopped, but we see little progress on WASH access despite the many co-benefits that WASH brings to a population. So how do you explain that? What are the solutions to speed up universal WASH access in Haiti?
Okay, if I can start, and then Bram can add something. So first of all, yes, we've achieved this incredibly important victory. We've had almost 2 years without any transmission. There are some great heroes, such as the ones that you saw on the screen. You know, the Vélin Joseph, you know, of ACF and others, both in the government and in the NGOs, mostly young people and mostly women, we must say. So now where are we? We are in a situation where we do need to improve the baseline. And so is that baseline improving? I think that you can see pieces of Haiti in the north, in the northeast, and in the southeast, some of which were cholera hotspots where, you know, through M-Water, we can see the tracking of that. And we do see some local improvements. But I think in terms of the larger macro vision, the jury's still out. And we've had our share, obviously, of challenges. We had the 5-pays look in the last 2 years, the social-political difficulties, and then we had COVID, so, you know, some internal issues as well. So it's been very difficult to push that baseline forward as is required in the BPO. And I think that's going to be our next challenge, because it's not only about cholera, it's about other waterborne diseases, you know, acute diarrhea, you know, typhoid and others. So there definitely we have our set of challenges. So Haiti Outreach, UNICEF, other elements have been moving the baseline forward, but we need obviously to do a lot more. Bram?
Yeah, thanks, Paul Christian. I don't have a lot to add to that. I would say though that there's a big difference between how effective the cholera elimination response basically has been. It's taken a while, but how great it has been compared to how little progress overall is being made in really sustainable access to WASH services. So the conditions for other outbreaks are still very much the same as they were 10 years ago. And so it does require huge investments. It does require prioritization. But it would be really a pity to lose the momentum now that cholera elimination is being achieved. That's all I would say about that. Thanks.
Okay, thank you very much. Time is running and time is over. So thanks a lot, Danielle and Stanislas, for your inputs. It was very interesting. So this is it. Paul Christian, you have now the floor to conclude the session. And just before, we keep questions from the chat and we compromise to give you an answer during the week. Paul Christian?
In less than a minute, the conclusion, some of which I just mentioned in my question. We were nearly 2 years without any confirmed cases. That's the victory. Again, this is a national victory. People like Vélin, like Mazar at ACF, you know, Jennifer at Acted, Wankos at Solidarité, people in the government, Edwidge Petit DINEPA, MSPP, people like Jocelyne, you know, Dr. Nathan, Dr. Celestin, these were key people in getting us here. But of course, we still do have these challenges. We have challenges in the WASH sector, and this is where we have to really improve the baseline in order to move things forward. And I think it is true that the rapid response mechanism, the cordon sanitaire, I think all the evidence is pointing to the fact that these very courageous women and men at the local level were the people who carried the day. So I think that really summarizes what we were discussing today. And thank you so much for participating, and continue to make a difference both in the water and sanitation field as well as the other avenues of your life wherever you are. Thank you again. Merci en pile.
Thank you. Do you have any idea for the poll results, Jean-Marc?
See.
Jean-Marc?
Yes, so from the poll side, so for question 1, so it was about CATI approach. So 57% of attendees are familiar with the approach. It's not so bad. For the second question, the second question was about the use of CATI approach or a similar one in a cholera affected country. 75% of attendees used or will use the approach. And regarding the last question, everybody, 100% of your answered well, yes. So everybody is very optimistic, which is good.
Thank you. Well, thank you, everyone. That was great working with you, sharing the experiences.
Thank you, Tiffany.
Goodbye.
Merci beaucoup.
Thank
Greg,
you.
thank you
you,
so
everyone.
much. Okay, kudos.
Bye.
Okay, merci, Greg. Okay.
Bye.
Well.